Session 8 describes the capabilities and the narrative around comprehensiveness of primary care. We discuss the impact of point solutions in primary care and touch on the emerging role of digital marketplaces. We also discuss how technology has increased the scope of what primary care physicians may be capable of.
What's interesting about this section is there's actually a debate going on as to what primary care should should and can do. Of course, in the academic sense of comprehensive care, good primary care should do everything. But current incentives, as well as some tech companies, are pushing the other way. On one side, you have primary care is more or less a middleman, or the people trying to unbundle primary care into a scattering of different point solutions, versus on the other side, people are saying, no, a primary care offering needs to have everything and should be empowered to do more, disrupting upstream, meaning taking more as technology improves, take more things from specialists and put them at the primary care level. Looking at the first side, the point solution side, the referral mill. Earlier, we talked about the incentives about how it's easier to, in the same time period, refer two people, generate two 99213s rather than actually take care of a person and generate one 99214. And that turns a fee for service office into essentially a referral mill. And there's actually this comedian that talks about how if there was a TV show about a primary care practice, it would simply be called the referralist. And primary care doctors should just give out discount codes to the specialists they refer to, since that's pretty much all they do. When we look at the point solution digital front doors, once again, looking at Row as an example, they do one thing and they've created these verticals, and pretty much all of these direct to consumer companies have their siloed verticals. If you follow that logic, really, patients should only engage with primary care for what they need, right? Instead of a bundled package, they can pick a la carte according to their individual specifications. And then you have marketplaces, things like digital.health, where all the things are on one place. And of course, Amazon being an obvious place to host all the point solutions and all the wearables and technology into one place, where patients can then order wearables themselves, track their own vitals, and then if they need things, go on a marketplace of point solutions to, again, a la carte, pick which things they need rather than pay for or go to a place that has everything under one roof. And arguably, the people who favor this side of things, besides for the misaligned incentives of the fee for service system, you can make an argument that if somebody specialized in something, they're going to be better at it. For example, Verta with diabetes, the protocol they generate and the resources they have for one specific issue are going to be far better than a generalist practice where diabetes is mixed in with hypertension, high cholesterol, arthritis, anxiety. When you broaden, the argument is that generalists tend to have a little shallower knowledge than specialists. But then going on the other side of things, the comprehensive care, one of the more idealistic archetypes or stereotypes of family medicine is the rural doc, the horse and buggy doc that goes town to town and can take care of literally everything. This narrative, this illustration is still sold to medical students today, where some of the family medicine departments will say, hey, if you love everything and want to do everything, go into family medicine because you get to do everything. And in the fee for service world, of course, that's not true. But there are places that are trying to make it a little more realistic. So, from a systems level, a multi specialty practice is probably a good example where you have a primary care doctor who has specialists that they can talk to and that they can easily refer to, often in the same building. Independent multi specialty practices, for some reason, have never really found big success in that they scale and do really well. This was something that was really popular and tried in the early 2000s. and for whatever reason, just never became a really sustained or sustainable business model. However, there are larger systems like Kaiser, which are more comprehensive and have a similar multi-specialty model. For example, in Kaiser, as a primary care physician, before you can refer, you actually have to message the specialist that you are going to refer to. They review the referral and either tell you something that you can do as a primary care doctor or go ahead and accept a referral. And in this way, this empowers a primary care doctor to do a lot more and refer less. And you see some of these same incentives play out in Medicare Advantage, where when you have the global capitation, you can take some specialists like ChenMed, for example. They are mostly staffed by family doctors, but then they'll also have certain specialties that rotate amongst their offices. And again, by doing so, reduce outside referrals and empowering the primary care doctor and the primary care office to do more. Direct primary care is similar, not because of the risk model, but because of offering a higher level of service for their patients. If they are able to do more things, then of course the patient will find the membership more valuable. And as tech improves, primary care doctors theoretically should be able to do more. From an education standpoint, you look at the resources available nowadays. Before, you would have to open up books, look for things, procedures were described in books. But nowadays, there's resources like Up to Date, which almost everybody uses. There's YouTube videos, Facebook forums where doctors ask each other questions. The resources are plentiful. The other things are more formal technology like e-consults. Just like Kaiser has their internal messaging system, e-consult platforms allow primary care doctors to message specialists and get some input to potentially save the patient from a referral. Then there are other more diagnostic tools like the handheld ultrasound, whereas before, ultrasound machine costs upwards of 50 grand for a machine and 10 grand per probe. Now you have things like the Butterfly, which are about $3,000, and that includes three different probes in one probe. Skin IO, allowing for AI recognition of precancerous skin spots, so doing a skin check, saving referral to dermatologists and so on and so forth. There are plenty of technologies out there now that can broaden what a primary care doctor can do without necessarily forcing them to go through many more years of training. Ultimately, comprehensive care and primary care will be up to the incentives and the willingness of primary care providers in terms of what they want to do. If more value based care or patient directed and patient focused care grows, then more and more care will become comprehensive and done at a spot. But if the volume based care or fee for service model continues to thrive and abound, and these direct to consumer companies really get a foothold, and it's where people go to and vote with their dollars, then there's a good chance that primary care, at least the point of first contact, will be one that is very fragmented, and people will essentially pick single solutions and bundle it together themselves based on their individual needs.
To summarize, we discussed some high level concepts about point solutions and incentives that influence referral patterns. We also described how technology has been enabling primary care physicians to do more than ever before. This concludes session 8.